So again, welcome to today's session, which is UT Talks from the Lab to the Village, My Career Path and Life's Work. Now, I do want to introduce you to our amazing faculty member that's with us today, Professor Obidimma Ezezika. He is an assistant professor teaching stream in the Department of Health and Society at the University of Toronto, Scarborough, and cross-appointed at the Dalla Lana School of Public Health. He is also an adjunct professor in the Faculty of Health Sciences at Ontario Tech University. Over the past 15 years, Professor Ezezika has led international research teams taking evidence-based interventions to scale through a variety of international organizations, including the United Nations Development Programme, Canada's International Development Research Centre, and the Sandra Rotman Centre for Global Health. His research interests lie at the nexus of implementation science, food security, and global health, and he was the recipient of the next Einstein Award for his emerging work in the field of implementation science. He is the co-author of the recent third edition of the book, An Introduction to Global Health, and the recipient of the inaugural University of Toronto Global Educator Award, which recognizes faculty members who embody the university's global mission and profile. As the founder of the African Center for Innovation and Leadership Development and a former Grand Challenges Fellow, Dr. Ezezika brings collaborative and internationally recognized leadership to innovative and leading edge research on taking interventions to scale to improve health equity outcomes. Welcome, Dr. Ezezika. We are so happy to have you here this evening to tell us more about your career path and life's work.
Fantastic. So I am so excited to be here. And thank you to Lydia and the team for organizing this. And again, welcome to my talk, From the Lab to the Village, My Career Path and Life's Work. So first, I will tell you a brief story about my career journey from engineering genes in the lab to working with farmers in African communities. And then I would take you through an interview I did, which was one of the catalysts that really sparked my career transition, my lab to village path. And then we would delve into two cases that would shed more light on the lab to village path. And then we would wrap it up with respect to a call for not reinventing the wheel. So here's a picture of me on the left at the Argonne National Laboratory, close to Chicago, shooting protein crystals. And if you want to know more about that, we can talk about it in the Q&A. And this was in the early 2000s. But then 10 years later, working with farmers and other agricultural stakeholders in Soweto, South Africa, and 10 other African countries. So you might ask, what led me to this transition, literally from the lab to the village? What led me to this path? You see, I remember vividly in high school, like many of you, and having this huge fascination for science, particularly the life sciences. And this led me to my PhD studies in microbiology at the University of Georgia, where I studied the microbial genetics of disease virulence and bioremediation. It was an amazing experience, no doubt. But as I got to the end of my program, my doctoral program, I began to wonder what was going to be the impact of my work in the context of the real world. In other words, I became so fixated on the challenge of taking research results into impact. And this was really introspective thinking with respect to what do I do going forward. And so this led me to policy studies at Yale, where I began to, for the first time, appreciate the complexity with respect to taking interventions from the lab to the village. And in fact, this is really the essence of implementation science research. You see, for example, it takes about 17 years on the average for an evidence-based practice to be integrated into routine healthcare. And half of those ever reach wide clinical usage. And so the question is, why? Why this complexity? Why this challenge? But one of the catalysts that really sparked this lab to village path occurred during an interview with the late Ananda Chakrabarty. You see, Ananda Chakrabarty was a renowned microbiologist and who was the first to create and patent a genetically engineered microbe that had the capacity to break down crude oil into water and carbon dioxide. That's amazing. Huge potential for cleaning up oil spills. You see, I was so fascinated by this. And as an early career microbiologist at the time, I was eager to learn the secrets of this scientific breakthrough and the next steps to real world impact. And thus my interview with him. But other than being awarded a patent, this microbe literally was sitting on the shelf. Now, that the history of innovation is littered with failure, that I understand. But to see the success, the obvious potential of this one trapped in the lab was really shocking to my younger and more idealistic self. But the interesting thing is, over the years, I have come to realize, that the path or the bridge from the lab to the village often breaks. And this is one of the things that drives me in the context of the lab to village research. Every scientist, every engineer, every politician, every entrepreneur experiences the delivery gap. And you too would do that at one point or another, because having knowledge about what works is no guarantee that it would reach the people it's intended for. And my research area of focus is Africa. And maybe Africa knows the story the best of all in the context of global health. I'll give you a case in point. So diarrhea. Diarrhea kills about 1,400 children every year. So by the time this talk is over, almost 60 children would have died of diarrhea. And it accounts for approximately 8% of all deaths of children worldwide in 2017. And this is despite the availability of a simple treatment solution known as oral rehydration salts, or ORS. And ORS is just simply any packaged rehydration solution that contains a form of sugar and some electrolytes like potassium or sodium. And the question then is, why is it that ORS, which is simple to make, and doesn't cost much, it costs just pennies. Why is it that it is not reaching all the children that need it the most? In fact, studies show that ORS only reaches four out of 10 children. And since 1978, the World Health Organization has actually implemented ORS in many countries, and there's been some success because almost 70 million lives have been saved due to ORS. But the question still remains that if every child who needed ORS got it, 93% of lives would be saved. So we know that ORS works, but why are we seeing a challenge in implementation or in adoption? In other words, how can we get to the six out of the other 10 children who need it? Because despite the simplicity of this innovation, less than half of children get it. And here's something also interesting. Even in countries with sound diarrhea treatment policies, there are still gaps. There are still gaps between policy and implementation. And to me, that is that is literally science sitting on the shelf. And this is where implementation science research comes in, or in other words, metaphorically, the research around the lab to the village. So let me give you a recent example of implementation science at work. With respect to ORS, or oral rehydration solution, implementation science would help and support the path on how to get to the other 6 children who are not getting the treatment that they deserve, because we have the intervention, we know it works, we know it saves lives. How do you get it to the other 6 children? That is where implementation science, or the lab to the village, that's where one can begin to think through the complexity, the ethical, social, and cultural issues with respect to getting these innovations to the people who need it the most. And a very good example happened in Tanzania, and a recent example. So we saw implementation scientists got involved in a local malaria program. And by systematically accounting for factors that might influence the use of malaria bed nets, and malaria is a major cause of deaths among children in many African countries, they were able to predict that families were more concerned about the nuisance of being bitten by a mosquito than they were of actually getting malaria. So while the government and donors' aims were to reduce the deaths from malaria, what they did was they designed their campaigns around promising families a peaceful night's sleep free from mosquito bites. And we're able to do this because of a deep understanding of what drives families to adopt malaria bed nets. And secondly, another thing that occurred was they were able to demonstrate that the color of the net affects efficacy or effectiveness. The reason is nets, or this malaria bed nets, which prevent mosquito bites, they lose their effectiveness the more they are washed. And while whiter nets are cheaper and therefore are the most frequently used, that choice can undermine the program's impact. And so these scientists, they leapfrogged over deep systemic and logistical challenges, and they were able to get the net into millions of people who needed it by a simple understanding of some of the challenges and the barriers. And for me, one of my personal missions is really how to get these innovations to scale, particularly into innovations that are evidence-based and have been shown to improve and save lives. So at the Global Health and Innovation Lab, where I work at the University of Toronto, we are exploring the ethical, social, and cultural issues around taking high impact innovations from the lab to the village, or from the bench side to the bedside, by leveraging implementation science research. And the ultimate aim is to close the delivery gap between interventions that are known to be effective and what is currently being delivered. And trust me, this can be a stubborn global health challenge, as we have seen with oral rehydration salts. So at the lab, we are using a framework that is called the Consolidated Framework for Implementation Research, otherwise known as CFIR, and other theoretical frameworks to evaluate a number of evidence-based interventions, particularly in sub-Saharan Africa, ranging from praziquantel, which is used in the treatment of a neglected tropical disease known as schistosomiasis in Nigeria, all the way to the meningitis vaccine program in Burkina Faso, from the Mom Connect program, which is an mHealth, a national mobile health program in South Africa, to the HPV vaccine in Rwanda. And through the lens of 39 dimensions of the CFIR framework, we are looking at effective implementation. And what are the key factors that predict how interventions can be implemented that range from the characteristics of the innovation all the way to the culture of potential users. And with that, we can better understand how any intervention can be fit for purpose in each real-life community in which it is applied, particularly where resources can be constraining. So going back to oral rehydration salts, essentially, implementation science, or the study of how to take innovations from the lab to the village, is the methodology for actually understanding how to reach 6 out of the 10 children. And so understanding the barriers to, or the challenges to implementing ORS offers a window of opportunity to critically examine how to scale and sustain ORS use. And this is, of course, most prominent in low and middle income countries or in developing countries. And our lab, the Global Health and Innovation Lab, has recently published results of a study that sheds more light on this. And this was published actually as hot off the press last month. And this was a study that was based on 55 articles across 23 countries over the last 40 years, and with the majority of countries being India, Bangladesh, Egypt, Nigeria, and South Africa. And the study uncovered barriers or challenges and enablers to ORS implementation. And so I have the 4 on the screen. I'm going to quickly go through each one and what we're able to uncover from that study. So the first was on availability and accessibility. And many of these findings are applicable to other interventions, but there's some things unique just about ORS. Programs need equitable distribution and reliable supplies. So if a program is going to offer ORS, it needs to get it to the people that need it on time and consistently. We also were able to uncover that costs can be prohibitive to uptake. If you want to save lives, you need to make it affordable, but also it doesn't matter how great the innovation is. If people cannot afford it or access it, they won't use it. The second one was on knowledge. And the issue of knowledge as a barrier included a variety of stakeholders from the study, ranging from healthcare professionals to researchers, from patients to family members, and critical to involve them in the discussion. Many voices, one vision. And the third was on partnership engagement. You see, buy-in and trust in a program has to be there from day one, from the onset. And this is where social mass media engagement, local engagement can be a great tool for increasing the awareness of a program, getting people involved, but more importantly, getting the local, state, and national governments to support these programs by virtue of the credibility that they bring. And finally, design and acceptability. And this is where local, community-driven initiatives work best. And locals can help design a program that works best for them. And so it is critical to listen and to include them. So the findings from this study actually did shed light that the potential, the prospect for actually closing that delivery gap or that lab to village gap would increase if implementation research is able to influence local applications. And so in Africa, in many African countries, we are seeing the potential of this kind of research. So we are seeing the ability of implementation science at work in designing and discovering and testing highly innovative approaches such as microfinance schemes, universal healthcare, social clubs, street dispensing machines, and even mobile phone technology like the Mom Connect program, which we are evaluating to provide HIV prevention, education, and many other health promotion activities, and even drones to deliver antiretroviral drugs. Implementation science can really help us do two things. It can help us avoid reinventing the round wheel, which is a waste of resources, but it can also help us to stop reinventing the square wheel, which is repeating what does not work. You see, the continual sort of reinvention costs time, it costs money, it costs lives. And in many ways, we've done the research. We know that these evidence-based interventions saves lives if they are carried out successfully. So the question then is, we have the will, how do we get the will into motion? And so to begin to summarize and conclude, implementation science, or the lab to village metaphorically, that research of trying to explore the ethical, social, and cultural issues with respect to taking innovations from the lab to the village, that kind of research can help us find out the nuances that make programs effective or render them failures. Comprehensive research in implementation has the potential to supercharge our predictive capabilities to address the most stubborn global health challenges, when it empowers us to decide for ourselves what innovations to adopt, but more importantly, how best such innovations can be scaled to improve and save lives. And this process really is the essence of my work. And with that, thank you so much.
Thank you so very much for such a phenomenal talk, Dr. Ezezika. I can't express to you how timely this discussion really is, given the current context that we are in, as we see cities, municipalities, provinces, countries try to distribute COVID-19 vaccines, PPE. This is such a timely discussion. So thank you so much for joining us this evening and sharing your research with us.